Dr. Charmi, I think we are already live. You can start.
Okay, I didn't. Okay. Uh, Very good evening, one and all, and warm welcome. Very good evening, one and all, and warm welcome. We have gathered here for an academic feast that is to follow. Heart failure is a pressing challenge in India with a prevalence of up to 4.6 million patients. Also, approximately 1.8 million hospitalizations occur in India due to heart failure, with in hospital mortality as high as 30%. Effective management of heart failure involves usage of GDMT drugs with mortality benefits along with other pharmacological agents and device therapies. To enlighten us on the same, we have the esteemed gurus of cardiology with us. I have the honor of introducing them. For the first talk on need and challenges in optimization of GDMT in heart failure, we have Professor Dr. Gurpreet Wander sir with us, who is Principal and Professor of Cardiology at Dayanand Medical College and Hospital, Ludhiana. Sir has numerous publications in reputed national and international journals like The Lancet, The Nature Genetics, JACC, EHJ, and Heart Journal. Throughout his distinguished career, Sir has received multiple awards and recognition to his name. We are honored to have you, Sir, and we welcome you. For our next second talk on optimization of GDMT in heart failure from bench to bedside, we have Dr. Tiny Nair sir with us, who is head of Department of Cardiology at PRS Hospital, Trivandrum, Kerala. Sir has received multiple awards for his exemplary work. Sir is in editorial board of multiple journals, is member of CSI and has authored 5 books and also has multiple publications in reputed journals. With this, we welcome you both. We welcome our esteemed speakers and we invite our first speaker. Over to you, sir.
Thank you, Dr. Charmi, for this introduction. And it's a pleasure actually to participate in a webinar in which Dr. Tiny Nair is going to present. Because whenever I listen to him, I always learn a lot about the management of different medical cardiac disorders. The task that has been assigned to me is to look at the need and challenges of guideline-directed medical therapy. So I would say we are essentially speaking on the medical therapy only. The devices have a great role to play in patients of heart failure, but that is something for another day because we will not be talking on that. As you all know, the heart failure is divided into, I will just introduce the topic to you. Stage A, that is a stage in which there are risk factors for heart failure, but the individual does not have heart failure as yet. Stage B is when symptoms and signs of heart failure are not there, but person has a structural heart disease, there are increased filling pressures, and there are various risk factors. Stage C is the heart failure patient which comes to you actually in your clinics, which you try to manage in your OPD settings. And stage 4 is actually by the time patient has acutely worsened, patient is in your ICUs or admitted in the hospital and is an acutely sick condition. Dr. Chami was saying high mortality in patients who are admitted, and this is in fact one of the markers of mortality in patients with heart failure. I will just make you familiar with some of the other terminologies which you might use. First time when heart failure is diagnosed, you will call it as de novo. They respond better. By lot many times, actually, your patients will have resolution of symptoms. The features of right heart failure, raised JVP, pedal edema, tender hepatomegaly would have disappeared. The left heart failure symptom of dyspnea, orthopnea, PND, or basal crepitation physical signs. So there is resolution of the physical signs and symptoms. Persistent is patient comes to you with one of these things that I have enumerated. And worsening is, of course, some precipitating cause of heart failure like anemia, thyrotoxicosis, pregnancy, arrhythmia, non-steroidal anti-inflammatory drugs, fever, infection, something has worsened your patient with heart failure. That's how you have to look at it actually. We all know the ESC guidelines, and now it's the most popular way we talk about heart failure. And primarily, I will talk about heart failure with reduced ejection fraction when the EF is less than 40%. But heart failure preserved ejection fraction is almost 50% of the total number of heart failure patients that we have. And heart failure with mildly reduced, what was initially called as mid-range and is now called as mildly reduced ejection fraction. These are two actually fractions, sub types of heart failure, which I will not speak about in the initial part of my talk, and I'll just have last 5-6 slides for clarification as to what is the approach. These are some actually changes in patients of heart failure which will happen, and as a clinician, it is very important that we keep in mind that a patient with heart failure reduced ejection fraction can remain as such or can have improvement in ejection fraction, and then we will call it as heart failure with improved ejection fraction. Especially ever since the advent of beta blockers, actually we now have patients in whom heart failure ejection fraction improves and they come to us with almost near normal ejection fractions. Heart failure with mildly reduced ejection fraction can worsen, improve. You can have EFs dropping to less than 40%, EFs remaining there, or EFs actually going up, and these patients then behave in a much better clinical format. Heart failure with preserved ejection fraction can again remain as such, go down, or maybe even become. So there is actually shifting which happens. Keep this in mind. So just as we were initially talking of diastolic heart failure, systolic heart failure, now we talk of heart failure with preserved ejection fraction and heart failure with reduced ejection fraction. And these are stages actually. So don't confuse the stages. And what we normally in our clinics, OPDs, we have is stage C patients, and stage D is what we treat actually in our ICU settings or in the admitted patients. Having talked of that, I'm going to primarily speak about the latest guidelines from the ACC AHA. And you all know ARNIs are today recommended as the three actually pillars initially, which are well known to all of us, are the RAS blockers, the beta blockers, and the mineralocorticoid receptor antagonists. These three pillars of heart failure reduced mortality, and our effort is to put all our patients on these three class of drugs and also to escalate the dosages so as to give them the maximum benefit from these agents. We know the two initial RAS blockers we used to use were the ACE inhibitors and the angiotensin receptor blockers. The receptor blocker that we most commonly used was valsartan because we have maximum data with valsartan. We have some data with candesartan and losartan also. Telmisartan is not used in heart failure. It's a drug which is to be used in hypertension. So over a period of time, actually after the paradigm study and a couple of other trials, we now know that ARNIs have better long-term prognostic outcomes as compared to ACE inhibitors and ARBs. And so you can see from the latest guidelines that ARNIs are recommended and ACE inhibitors are beneficial when the use of ARNI is not feasible. So there is a significant change from what we used to do 10 years back. We today prefer ARNIs as the agents of choice. This is actually the latest expert consensus. So I will also touch upon this because this puts the whole thing in its right, the latest perspective. And as I said, if you are changing over from actually your patient is already on enalapril, which is an ACE inhibitor, or valsartan, which is an ARB, equivalent dosages if patient is less than 10 milligram, then you put them on 50 milligram twice a day. But if your patient is tolerating more than, and keep this in mind, if your patient is on ACE inhibitors earlier, ensure 36 hours off because patients can have actually angioedema. But this is not required when you are shifting a patient from valsartan or losartan on to the Arnie's, the valsartan sacubitril combination. So one of the three RAS blocker should be given to all patients of heart failure, and there is a significant reduction in mortality with these. As I said, the second very important group of agents is actually beta blockers, and the three beta blockers that are used in this are carvedilol, sustained release metoprolol succinate, and bisoprolol. Beta blockers should be given to patients in all stages of heart failure that I spoke of, because they reduce mortality, they improve ejection fractions. But one of the dictum from the 2024 expert consensus is start slow and keep increasing the dose every 2 weeks. Monitor their blood pressure, heart rate, signs of congestion, and preferably actually iurize your patients, make them feel better, and then start them on beta blockers and also the RAS blockers. Mineralocorticoid receptor antagonists can be used if GFR is more than 30 and serum potassium is less than 5. Keep in mind that combination, the most commonly used agent is spironolactone. If your patient has, these days, finerenone is also available, non-steroidal mineralocorticoid receptor antagonist. Aplerinone can be used if your patient develops gynecomastia with spironolactone. In that situation, you can use aplerinone. Usual dose that we start is 25 milligrams. We go on to 50 milligram. But as I said, actually, monitoring potassium is very important in these people. The 2024 guidelines again suggest, actually, the expert consensus tells us that we need to monitor potassium because hyperkalemia can occur. This is actually the first trial, which was WellHealth trial, which was done with the afterload concept of afterload reduction came with hydralazine and isosorbide dinitrate. We today use this combination in patients with renal failure where we cannot use one of the three RAS blockers, but it's an agent which is preferred in the Western world for African because they respond better to this hydralazine and isosorbide dinitrate combination. Coming back to the stages that we spoke of, if your patient has stage A, there is a risk factor. You will have a multidisciplinary approach to actually reduction of the risk. And of course, SGLT2 inhibitors can be used in patients who are diabetics and who are at a very high risk of CVD. You will try to control blood pressure at this stage. If your patient is in stage B, no symptoms, but ejection fraction less than 40%, you must put your patient on ACE inhibitors and also beta blockers. If your patient, we are not talking of devices, but yes, if EF is less than 30% and if patient is 6 weeks post-MI, you need to put them on an ICD to prevent. As I said, these three agents are actually the three pillars, and now the fourth pillar is very familiar to all of you, the SGLT2 inhibitors. So these four agents have to be given to all patients with heart failure with reduced ejection fraction. And in special situations, you will use actually some of these other agents. Now, if your patient is actually having volume overload, you would like to put them on diuretics. So you would see that diuretics come as only add-on symptom relieving agents, the loop diuretics that we use, because they do not actually reduce mortality, but they are of great use in reducing symptoms of patients. So you will put them on diuretics, add agents which reduce mortality, and as your patients get decongested, you will try to reduce the dosage of loop diuretics. As I said, now if your patient is on beta blockers and the heart rate still remains beyond 70, then ivabradine is a very good agent and it reduces the heart rate provided your patient is in sinus rhythm. We will talk a little bit about vericiguat in patients who have been hospitalized and who are not responsive. So these are actually digoxin now. See, one of the first agents to be used more than 100 years we have used in heart failure. Digoxin actually reduces heart failure hospitalizations. So it's a class 2B indication, but patients at times you need to use it, especially in those who are in atrial fibrillation for a good rate control in these people. As I said, ivabradine should be used in people more than 75 years of age in a dosage of 2.5 milligram twice a day, and in less than 75 milligram, 5 milligram twice a day with food, so as to enhance its effectiveness. But make sure and be actually certain in your mind that beta blockers are the agents which reduce mortality, but where you cannot use beta blockers due to very bad COPD along with that, or if patient's heart rate is not coming down, then obviously. Now, this is some data which we actually have our own Indian data. The Asian heart failure trial was a large trial, and we were one of the participants in this. This was published in Lancet Global Health. Having spoken of the pillars of treatment of guideline-directed heart failure, let's see how we are doing. It's a large trial, 6,400 patients. 81% of the patients were heart failure, reduced ejection fraction. And if you look at it, actually, whether you are in China, India, or anywhere, the percentage in whom we achieved actually guideline recommended dosages was only 17% of these patients were on ACE arms, the adequate dosages. Of course, a lot of them, almost two-thirds of them were on these agents. So why I'm showing this slide is because we want to emphasize that at times we become very complacent that I have started my patient on ACE on a RAS blocker, beta blocker, and an MRA, but try to achieve the guideline directed medical therapy dosages, which would be actually 200 milligrams of metoprolol or 25 milligram twice daily of carvedilol or 10 milligrams of bisoprolol. And similarly, actually 40 milligrams of enalapril or 100 milligram twice daily of the ARNIs and 50 milligrams of spironolactone. So those are the maximal dosages. And this particular trial showed us actually the Asian heart failure that if you give lesser dosages, you give some benefit to your patients, surely. But if you go up on the dosages to the maximum tolerated, you will actually be giving greater benefits. Lot many patients actually go out to, they are seen by chemists or non-medical people. They record their blood pressures and they come back and say blood pressure was low, so I reduced. So counseling of patients, I think, is very, very important. This is another very important slide which I wanted to share with you. Now you put your patient on RAS blocker, beta blocker, MRA, SGLT2 inhibitors. Your patient's ejection fraction improves, your patient's symptoms disappear. Please do not stop their drugs because the Trend HF trial showed us that 50% patients with relapse in 6 months if you stop their treatment. So continue on beta blockers, RAS blocker, MRA, even if the ejection fractions have come up and the patient symptoms have disappeared, because when they relapse, they do not respond as well at that stage to the same group of drugs. So at the cost of repetition, I would again emphasize now one of the two RAS blockers, beta blocker, MRA, and dapagliflozin. That is how we visualize actually Dr. Tiny Nair and I have been co-authors to this actually the place of SGLT2 inhibitors in heart failure, and we know they have effects on the heart, the kidneys, and the vasculature. And that is how three of the SGLT2 inhibitors, dapagliflozin, empagliflozin, and sotagliflozin, have been shown to be of benefit in patients who have actually eGFR of who do not have actually GFRs less than 25 ml per minute per meter square. So beyond that, actually, all these patients should be given the benefit. And this is a beautiful slide which shows that the 2-year mortality is 35%, something what Dr. Chami said. You put them on ARNIs, you reduce it to 25%, put them on a beta blocker, additional reduction, put them on an aldosterone antagonist, and put them on an SGLT. The order is such because that's how we, generally these agents have come to be. And the absolute risk reduction is 25%. Number needed to treat is just 3. So we must impart benefits to our patients. This is another similar, just to emphasize to you that this is a meta-analysis by one of my mentors, Dr. Inder Anand and Dr. Caroline Lam from Singapore. Now, this beautifully, actually, you can see that if you put them on ACE inhibitors and beta blockers, the hazards ratio is reduced to 0.6. You add a MRA, hazard ratio is reduced to 0.38. And you add ARNI, beta blocker, MRA, and SGLT2 inhibitors, the hazard ratio is reduced to 0.3. So look at the amount of benefit we give to our patients when we combine these agents. This is another agent which has come now, which is available. It is expensive, very cigarette. Actually, you will be using it over a period of time. And there is data actually with very cigarette that in patients who have been hospitalized, in fact, there was a study published about 4 years back in the New England Journal of Medicine by the name of Victoria study. And ever since, we all use very cigarette in resistant patients who have been hospitalized, who are not responsive to the four pillars of heart failure as an add-on in a very selective group of patients, not in all patients. I would now be actually just introducing Indian, how we are different, and then maybe we will be looking forward to Dr. Tiny Nair's talk after this. Well, our patients are younger by 10 years, male predominance is there. Almost 80% of our patients of heart failure are due to coronary artery disease. And as said, you have already been told, 1 year mortality is 31% amongst patients who are hospitalized. This is some beautiful data actually from the Asian heart failure, which I thought I'll share with you. We all know that patients who have actually the central type of obesity, they are the ones who have the lean fat people actually. They have 22% primary events as compared to obese who are not centrally obese. So our syndrome X, central obesity actually also translates. You all know that there is a obesity heart failure paradox. People who are relatively overweight, they have better prognosis than very thin. But look at this data from our country, from the Asian nations, which shows that it's the central obesity which has not only effect in coronary disease, but since coronary artery disease is the major cause of heart failure in our country and also world over, this is how it runs. These are the Indian guidelines which were published. I just brought it because I wanted to bring some actually vaccination is important in these people who are very sick. And now we will be coming to those months when H influenza and pneumococcal vaccine should be a part of your therapy if you want to reduce hospitalizations. Iron is helpful in a selected group of patients. These are 10 pivotal issues which have been given in the latest 2024 guidelines. And for want of time, I think I will just skip those. I will just spend one more minute on heart failure with preserved ejection fraction and mildly reduced. You know, this happens in older people, more often in females, hypertensive, diabetics, those who have obstructive sleep apnea. And you need to exclude these additional factors like anemia, thyroid, COPD, and CKD. But actually, I just wanted to show you that all these agents, the RAS blockers, beta blockers, and MRAs, which have been shown to reduce mortality, it's a class 2B indication in heart failure with preserved ejection fraction. Even in mildly reduced ejection fraction now, SGLT2 inhibitors are 2A, but RAS, MRAs, and beta blockers are 2B. You will, of course, use these agents because hypertension is one of the major causes of these. Even preserved, it's similar. And I would end by reading this very important and something that I really like. The best physician for a patient with heart failure would be one with excellent training, extensive experience, and superb judgment with regard to all aspects of the disease. And I know you all are excellent physicians, so you will use your individualized approach to treatment of heart failure. He or she would not necessarily follow guidelines slavishly. We are just actually bringing the evidence-based data to you. You will obviously use discretion in managing your patients with heart failure. And thank you for your. Over to Dr. Tiny Nair, please.
Thank you, Wonder Sir, for that very clear overview on heart failure. Give me a moment, by the time I share my slides. My slides are visible, and am I audible?
Yes, sir.
Thank you. So we would be looking into, now you have the background of what is the burden of heart failure, how basically the guideline-directed medical therapy guides us as to how we should go ahead and treat heart failure. Now we will touch upon certain things that always troubles us, things that are interesting, but let us start with the first basics. And that is the natural history of heart failure. Right. When we talk about the natural history of heart failure, understand that the natural history of heart failure is like this. We have all seen this graph, but it is worthwhile going through that again. Right? We know that most heart failure patients would come to a hospital with an acute pulmonary edema, worsening heart failure. May not be pulmonary edema, but at least a swollen leg, elevated JVP, he is fatigued, he has heart failure, acute worsening. He's in the hospital, and exactly like you see the curve, he becomes better. That dip becomes a flat line, and he is better. Right. So he is in a stable state, and he is fine. He thanks you, doctor, because of your treatment, I have become so well, and he goes home. But what is not commonly seen and understood is that there's a long story after that hospital discharge. Given some time, this patient tends to have a recurrence. Okay, and you see those dips again and again and again. There are multiple hospital admissions, right? So they get multiple hospital admissions, which we call as heart failure hospitalization. And finally, over time, we know at the end, there is mortality. So this is the reason that when we talk about any heart failure trial, you would have seen that the endpoints are one, death, obviously. Does this treatment improve survival? And the second, does it reduce heart failure hospitalization? It is not because just the burden of on the medical system, the cost or the stress on the family, but as you see, every hospital admission, the graph goes down and down and down. So the patient becomes worse and worse and worse. And that is why today we say that once the guard gets started getting a recurrent hospitalization, we call it worsening heart failure. We have seen Professor Wander's beautiful slide, which defined what is worsening heart failure. So de novo is the first admission, worsening heart failure is subsequent heart failure admissions, right? So we have a window of opportunity now, which spreads right from the beginning when he comes with the first acute pulmonary edema, or even before, in preventing heart failure, as you saw, type A, the stage A, right through till he is extremely sick in the hospital. Right. So you have a huge window of opportunity today. But this is something which we normally forget. We always talk about mortality, heart failure, hospitalization versus heart failure, big terms. Right. But what the patient comes and tell you is that, doctor, I am feeling bad. Right. I can't walk much. I feel fatigue. Now look at this data. This is total self-reported score in diseases. On the top, you are better than normal. In the bottom of the line, you are worse than normal. So the first line you can barely see is a blue line, blue graph. That is hypertension. Hypertension patients have no symptom, right? So how are you? Oh, I am fine, sir. Yellow, you see diabetes. Maybe he has got a peripheral neuropathy, he has some autonomic issues, he has some giddiness, he has polyuria. He doesn't really feel well. Okay, look into the orange and the red, arthritis, angina, right? They are worse. So they actually come and tell you, doctor, I'm not feeling well. Do something about it. Okay, what about chronic lung disease, COPD? Pocket filled with inhalers, with a nebulizer in his bag. This man is really, really troubled with his symptoms. But what we don't realize is that when we are talking about heart failure, they have a huge burden of symptoms. Right, dyspnea, unable to walk, fatigue, giddiness, our drug-induced problems. So they have significant burden of problem. So any treatment, guideline, no guideline, GDMT, no GDMT, we offer them. He would want that, Dr. Saab, will this reduce my symptoms? So he needs to feel better. So this feel-good factor needs to be considered when we consider any treatment for heart failure, symptomatic improvement. Something again that we miss out in this entire life story graph of heart failure that we talked about is the unexpected. Yes, you are right. It is sudden cardiac death. See, this is an old data from the MERIT-HF trial, 1999, but nevertheless, it speaks of the truth. Class 2 heart failure NYHA patients, 65% die suddenly. And similar number, very high numbers, 60% in class 3. They have now changed. but understand the burden of sudden cardiac death, right? The terminal heart failure, the class 4 person, the death is mostly driven by pump failure. But the class 2 and class 3, they can have sudden cardiac death, presumably resulting from arrhythmias, right? So any treatment that we are talking about, GDMT, no GDMT, should reduce sudden cardiac death. And that is the reason, that is the very reason why when we talk about the fantastic 4 heart failure treatment, understand that when we talk about SGLT inhibitors, ARNI, MRA or beta blockers, those are the fantastic 4, the 4 pillars of heart failure treatment. Why are they fantastic 4? Simply because all these 4 in varying degrees improve survival. They reduce hospitalization of heart failure. They reduce sudden cardiac death and they improve symptoms. So we call them fantastic 4 for a reason, because these 4 improve 4 very important endpoints of heart failure. They improve survival, reduce hospitalization, reduce sudden cardiac death, and improve symptoms. And that is why they're so very important that we apply them in therapy. Now, this is probably, you are taking on one slide, this is it. This Dr. Wander already said, but it is always worthwhile repeating in your mind, right? Stage A heart failure means they have no heart failure, but they're at risk of developing heart failure, right? So, for example, today SGLT inhibitor trials have shown that if they're diabetic, if you give SGLT inhibitor to a diabetic patient who does not have heart failure, their development of future heart failure is reduced. Fascinating, right? So you have a stage 1 person, stage A person, means he has no heart failure, he has just risk factors for heart failure, and you treat, and they don't develop heart failure. Right? That is fascinating. Right? Talk about stage B, which means they have heart disease, but no symptoms. Echo shows maybe some ejection fraction low, or they have a valve disease, or they have an elevated NT-proBNP. But how are you? I am fine. And at that stage, we see all these blue are today class 1. SGLTs are indicated, ACE inhibitors indicated, ARB if ACE inhibitors are intolerant, and beta blockers are indicated. Right. So asymptomatic heart failure, you have indications of RAS blockade, you have SGLT inhibitors and beta blockers. Right. Now, if you have symptomatic heart failure, stage C, stage D, people that we see as doctors, right? They would come and say, I have some symptoms, stage C and stage D. If their ejection fraction is low, HEF or REF, ejection fraction less than 40. Look at those class 1, blue, ARNI, if, or at least ACE, ARB, right? Beta blockers, MRA, SGLT inhibitors, these 4. So the fantastic 4 comes in when you have ejection fraction less than 40, right? If your patient is congested, diuretics as needed, class 1, and exactly like Professor Wander showed, hydrazine nitrate combination for specific subgroup of patients. Okay, what about those who have a mid-range ejection fraction? 40 to 49, 40 to 50 basically. Diuretics if congested, SGLT inhibitors 2A, right? And of course, in 2B, you have ACE, ARB, ARNI, you have MRA, beta blocker, right? And if you are looking at ejection fraction more than 50, similar, SGLT inhibitors and diuretics, if congested, SGLT inhibitors 2A, we know that they are indicated, they are one of the best. If there is an FPEF, and of course, ARNI, MRA, ARB, similar like heart failure with mid-range ejection fraction or mildly reduced, whichever way you call it, MS. So that is the entire spectrum that we know. Now, we know today that we have basically 3 limbs to address: neprilysin, sympathetic nervous system, and RAS. Sympathetic nervous system is cut out by beta blockers, RAS by ACE and ARB. But the neprilysin pathway, which was kind of unattended for a long time, is inhibited by sacubitril, and that is why today sacubitril plus valsartan, that combination gives us kind of blockage of all 3 neurohormonal activation pathways, right? And that is why we talk about the combination therapy. But understand that today, this is because we are talking about what the bench tells us about bedside tomorrow. The ARNI story is changing rapidly. All these years, what we were teaching students is valsartan inhibits angiotensin 2, and sacubitril inhibits neprilysin pathway. Yes, that is true. But today we know that there's a huge amount of stuff going beyond the receptor level, right? The NPR, A receptor, B, C, the interaction with the angiotensin receptor system and the sympathetic nervous system, so that diseases like heart failure and beyond, dyslipidemia and metabolic diseases, portal hypertension, pulmonary hypertension, systemic hypertension, the basket of sacubital valsartan is increasing. So what the bench today promises is that tomorrow bedside, this perhaps is going to be far more important. Now, before we leave army and come out, there are some forget-me-nots for India-specific treatment, and this is here. You know, this beautiful article came in JACC, sacubital valsartan, 5 years after paradigm. Beautiful article, right? And that showed that, yes, that is what we know. If we look into all-cause mortality in heart failure and put a straight line there, look at that. ACE, beta blocker, MRA, RNA, SGLT inhibitor, all of them improve survival, right? Now, the point is, basically, in our mindset, we always think that ACE and RNA are similar, right? RAS inhibitors, both are RAS inhibitors. So in our mind, we always think ACE and RNA are similar. So a patient who is on ACE inhibitor, beta blocker, MRA, SGLT, he comes and says, how are you? I am fine, sir. We say, okay, you continue. We don't realize that we might benefit much by converting that ACE inhibitor to RNA. Do you realize that? In fact, if you take out the paradigm data and see RNA versus ACE inhibitor, you reduce all-cause mortality with an NNT, number needed to treat, of 21. Fantastic, right? So, your patient who says on ACE inhibitor, I am fine, still there is a logic, there is a reason, there is a logic why we should change it to RNA, because we are reducing his mortality, right? So this is important that ACE and RNA, though they work in the similar direction or a similar pathway, has tremendously different benefits. RNA over ACE inhibitor. So probably it is mandatory that we change it. Now, this beautiful article on sudden cardiac death by John McMurray came in NEJM, and that beautiful graph, you also know that graph, which looked into the data of sudden cardiac death from 1995 to 2011, showing very clearly that one of the lowest is in paradigm HF when people were treated with RNA. So yes, RNA has got a benefit of reducing sudden cardiac death, presumably by improving LV function, right? And this is here the topic we are today talking about, what is new dictated by the bench, the lab, and that translates onto the bedside, right? Look at that. Now, this beautiful piece of article came in JAMA called On My Mind, is sacubital valsartan and anti-arrhythmic drug, right? We know that, okay, sacubital valsartan, look at the data. They reduce myocyte death, reduce hypertrophy, they reduce fibrosis, they decrease inflammation by effect on both angiotensin system and neprilysin system. And so there is better remodeling, what we call as reverse remodeling. So the ventricle becomes smaller, becomes better performing, and so there is less arrhythmias and reduction of sudden cardiac death. But understand that today in the bench, we are talking about something more. We're talking about, this is why we showed you that neprilysin data. Neprilysin turns out to have an anti-arrhythmic effect, right? So neprilysin might have an individual anti-arrhythmic effect by which it reduces some cardiac death, exactly like beta blocker, on top of beta blocker, and give us a benefit. So the new research at the bedside is quickly changing the way we are devising our algorithms and the way we use GDMT, right? Now, this is a question that everybody asks, sir, all these trials are done in the Western population. Are they really useful for us? So if we look into the paradigm data, 468 patients were in the India, they partook in paradigm from India, 468 patients. And there's data available on these patients. So if we look at the primary composite endpoint, look at the hazard ratio and p-value interaction, we see they're same. It was the benefit that the international patients got worldwide with RNA in HFrEF also translated on to Indian patients, right? Whether you are looking at cardiovascular death, whether you are looking at heart failure, hospitalization, whether you are looking at all-cause death, yes, we see that the p-values are no different, which means the benefit that the international patients got with army was also there in Indian patients. So yes, it is effective in our population. Please see that you use it optimally, right? But hold on for a moment, right? This is our data that we published, Trivandrum Heart Failure Registry, from our own city of Trivandrum. 1,200 patients. Initially, it came in American Heart Journal in 2015, and subsequently we got it published onto almost every top journal. And recently, we published the 5-year follow-up data, right? And what we learned was fascinating. 50% mortality at 5 years. Okay, so our patients 50% die at 5 years. But there is more. This is what actually made us sit up. You must have seen this, because whenever I talk, I show this data. If you're not seen this, watch carefully. So if we look into the x-axis, follow-up time after discharge from hospital, 0, 20, 40 days after hospital discharge. And in the y-axis, you have cumulative mortality, not any soft end point of hospital admission, mortality, death rate. See that to those patients who received guideline-directed medical therapy, right? They did so well. While patients who did not receive guideline-directed medical therapy did bad. In fact, their event rate was 3 times higher. The blue line was 3 times higher. And what event are we talking about? Cumulative mortality, nothing else, mortality. So your prescription at hospital discharge for your heart failure patient determines his outcome. But not prescribed correctly, his mortality rate is 3 times higher, right? But what pained us is this. We found that only 24% of our patients received GDMT. 76% didn't. See, in Kerala, we always pride ourselves that we have the best medical system. Our infant mortality rate is 4.5 today, and we give everybody guideline-directed medical therapy. We are wrong. When we looked at the heart failure data, we were shocked to see that 76% of our patients did not receive guideline-directed medical therapy. And you know what is guideline-directed medical therapy? This is 2015, right? So for us, the guideline-directed medical therapy was not a fancy SGLT inhibitor, not an ARNI, but just ACE, beta blocker, and aldosterone antagonist. So spironolactone, a beta blocker, and an ACE inhibitor was not given at discharge to 76% of our patients. We didn't give them. So we are at fault, right? So we did very badly. So understand that there's a huge gap between the guideline-directed medical therapy and what we practice at baseline. So this is the data of ARNI use in India. You can see that if you that straight line I drew, look at that, less than 5%, right? So use of ARNI is less than 5% in Indian heart failure patients. And all of us, me and Professor Wonder, we pray and hope that this will improve, because today ARNI is available very cost effectively in India, unlike the West. So yes, this should improve to improve our patients' outcome, right? Now, one small thing that we should not forget is this, right? See, when we look into heart failure, they can present in different ways. Heart failure patient can come in the ambulance. We look at ambulance, right? They can come to the hospital in the intensive care, followed by that hospital stay for a long time. They can come with a diabetes, very high blood sugar, or a non-diabetic. A heart failure patient can have an ischemic heart disease or a dilated cardiomyopathy, non-ischemic. A heart failure patient can be young, old, debilitated, or active. A person can be thin or obese. A person can be severely symptomatic or fairly asymptomatic, right? Whatever. So they present in different ways. Not just that, some of them, as Dr. Wanda showed, half of them would have reduced ejection fraction, half with preserved ejection fraction. Huge, wide spectrum, right? Now, if you look into the SGLT inhibitor data and look at those 5 randomized trials that we have today, everything, all the data that we have, DAPA-HF, DELIVER, Emperor reduced, Emperor preserved, and so is WHF. And we have about 21,000 patient data. Okay, let us quickly see. If you look at people more than age 65, elders, yes, they benefited. Look at that. Everything is on the left of straight line, right? So elders, young, benefited. What about women? Most heart failure data don't include women. But look at that. SGLT inhibitor benefited. Right? Look at diabetic status. Diabetes, no diabetes. Benefited. Similar benefit. Body mass index. Fat, thin, less than 30 BMI, more than 30 BMI. Similar benefit. So what we are talking about is SGLT inhibitors tend to look at GFR. eGFR less than 60, more than 60. Heart failure hospitalization, short term, long term. Everybody seems to benefit, right? So we are talking about this. SGLT inhibitors are indicated for all. So the benefit of SGLT inhibitors is that it benefits almost every subgroup of patient that we talked about. Thin, fat, young, old, debilitated, elderly, young, ischemic, non-ischemic, DCM. Okay, everybody tends to benefit. But being carried away by the benefits of SGLT inhibitors and ARNI, please do not forget that there is something more, and that is beta blockade. It is extremely important in India to realize that, yes, we should not forget beta blockade, because beta blockers are one of the cheapest drugs available. And I see that the newer generation physicians, the youngsters, tend to be attracted more to ARNI and SGLT and forget beta blockers. Beta blockers are one of the finest drugs available for the treatment of heart failure. That's why we say that Indian forget-me-not is a beta blocker. And why are we talking about that? Look at our Trivandrum heart failure data again. This is from Trivandrum heart failure data registry. We were trying to see factors that had a say on a 5-year mortality. And you see what we found? Look at that. The lowest hazard ratio was 0.55, which was a discharge prescription of beta blocker. Did you get the importance of the point? So your beta blocker at discharge for your heart failure patient determines his 5-year mortality, and that is reduced by 45%. One of the strongest markers that your patient is going to live longer is your discharge prescription of beta blocker, hazard ratio 0.55. So please make sure that your patient of heart failure, if he tolerates, if he's going home, is on the standard GDMT, and please do not miss out beta blockers in India. Right. This is, you have already seen this, right? How beautifully Professor Wander has shown you that as you graduate from ACE plus beta blockers to MRA plus everything, you benefit. But I'm showing you for this, benefits. Why I'm showing you is this. Look at that. Every heart failure trial, every one of them is built upon the foundation stone of beta blockade. Every heart failure trial is built upon the foundation stone of beta blockade. There's no treatment of heart failure, reduced ejection fraction, without beta blocker. So please do not forget beta blocker, one of the cheapest drugs, but one of the most effective despite introduction of the new medications. We will finish off with the concept of early start. We know today we are talking about early starting. We have the beta blocker data. Look at the beta blocker data. Copernicus, for example, if you draw a line there, you see by week 3, you see the benefit of beta blockade clicking in. Right. Look at the data of MRI in emphasis trial. See, significant benefit of blue and red right from the beginning. Look at ARNI. Look at Pioneer HF data. Benefit by 2 weeks' time. And of course, you must have seen this enormous number of times the SGLT data of dapagliflozin, which shows very clear benefit at day 28. Day 28. So imagine by the time your patient comes for the first follow-up, it is 30 days, right? Before that, he can have an event. So the best time to start is right in the hospital before the study. It is challenging. It is not very easy. But even if it does not tolerate full dose, it is worthwhile to give small dose of these 4 agents in a small dose before they go home, if they tolerate it, right? Because you are altering their long-term outcome. So it is important that we put them on medicine right as early as possible. But when we are talking about early, this is the GDMT. Today, what we talk about, we say that start early. See that day one, we say initiate low dose of ARNI, low dose of beta blockade, MRA, low dose and SGLT is only one dose, right? But when we say day one, understand it is not that day one when he is in the intensive care unit with a BiPAP, ventilation, oxygen and inotropes. The day one means we are talking about a person who is off IV inotropes, who is on stable dose of diuretics, who has stable hemodynamics. That is his day one. So after his crisis is out, he's off ventilator, he's maintaining his saturations, so off IV inotropes, that is the best time when you can start the disease-modifying therapy, combination of ARNI, beta blockade, MRA, and SGLT inhibitors. Earlier you can initiate, the better outcome you get, right? Now, these are early warnings that don't feature in a GDMT. But I think when we are going from bench to bedside, we should not forget them what? A simple weighing scale. Ask your patient to buy a weighing scale and keep it in his bedroom. Your heart failure patient should weigh them daily. Increase in body weight indicates he might be retaining fluid. And in the next 2 weeks' time, he might land up in your intensive care unit. He might need a change of diuretic therapy if he weighs regularly and tells you that his weight is increasing. Blood pressure apparatus. Today, everybody has a blood pressure apparatus at home. They can always follow up their checkup whether they have hypotension or rise of blood pressure. They can always report their SpO2 and heart rate to you, right? And that could act as a simple home warning. Hypoglycemia is known to be a trigger for many arrhythmias and worsening heart failure. Intercurrent infection that people are so prone to, heart failure patients, be it pneumonia or whatever, can have bad outcomes. Elevation of body temperature warns them that they can have an intercurrent infection. They need to go to the hospital. So a simple thermometer, a glucometer, a weighing machine, a pulse oximeter, and a blood pressure apparatus, which can be easily acquired at home, could give you very good information, which can supplant, which can add to your GDMT in the West. Now, before we finish, understand that we always talk about natriuretic peptide system inhibitor. What? ARNI. See that top part of the slide. We talk about sympathetic blockers, the beta blockers. We talk about RAS inhibitors, ARB, ARNI again, right? But when we talk about these in the clinical sense, we forget there's a huge amount of bench and stuff that is going on, right? You have very complex interaction of neurohormones, as you see there. And that translates into a complex biochemical receptor system that tells us about, ACE inhibitors, sacubitril, valsartan, SGLT inhibitors, vericiguat, omecamtiv, mecabril, and gene therapy and everything together. But it is important to realize that, are we there yet? Yes, we are talking about bench. So much of research has come today. We can talk about hours and hours on that. But it translates to nothing unless that goes on to the bedside and gives benefit to the patient. We are not reaching that goal, right? But today we are realizing even that bedside, the GDMT is not enough. We have far more steps to cover. And what is that? And that is the patient has to take the medicine. I have to prescribe the medicine and the patient has to take it. So the physician has to be empowered to understand why that bench dictates the bedside and why that bedside should translate into his prescription tomorrow. Why your patient taking ACE inhibitor, even if he is fine, should be changed to an ARNI. Why you should not forget writing beta blockers at discharge because it gives you a hazard ratio of 0.55. That is why the topic today was translating the information at bench, what we researchers gather, not just at bedside, but translating onto patient so that he takes it and gets the entire benefit of the heart failure treatment, an excellent set of treatment that we have available to us today. So thank you for your time and attention, and we are available for any queries that you have. I will share the screen and give the podium back to the organizers.
Wonderful, sir. I must be honest. So we have 3,000 doctors hearing the session as we speak. We've got phenomenal responses for the talk delivered by yourself as well as Professor Wonder. So with your permission and with the kind permission of Professor Wonder, if we can go ahead with some audience Q&As, because we've received a lot of them, very quickly with your kind permissions. So the first question is from Dr. Anand, who asks, would you start all drugs at the same time or one after the other in rapid sequencing? You have discussed this very well, Professor Tiny Nair, sir. He also asks your tips and tricks, and he specifically mentions, I start MRA usually 2 weeks after RNA due to a risk of hyperkalemia. I wish to learn from the experts. Dr. Anand.
I think, see, the whole concept is previously we were talking about sequential addition of medication. So we give one medication, send the patient home, he comes back, we add the next medication, and next, again, understand that all these medications are personalized, dependent on one person who is a gross diabetic, who is fluid overloaded, he would probably benefit best by starting SGLT, right? A person who is ravaged by RAS, he would probably benefit by an ARNI. A patient with a tachycardia, rapid heart rate, sympathetic driven would benefit by an beta blocker. But everybody needs everything. So your choice of starting sequential, the issue came in that many patients would come back in about, say, 2 weeks or 3 weeks with another event, another pulmonary event, or another cardiovascular event, right? Or maybe a sudden cardiac death. And then you, oh my God, we should have started this drug early, right? And we have drugs today which have shown, whether you are talking about MRA, ARNI, SGLT inhibitor, beta blocker, they act fast in reducing event rate. So that translates onto the question that can we start quicker and quicker and quicker? So from the sequential, we have simultaneous starting of drug today is the strategy now. Okay. Now the challenge of simultaneous is well known. You give all the drugs together to a person who is already in a poor LV function, he will get into severe hypotension, right? He will get into severe electrolyte disturbance, hyponatremia, creatinine will shoot up, his potassium will change. That we all know. So you need to, that is why we say treatment of heart failure is an art. If you remember Professor Wander's last slide, it's an art. You need to start extremely slowly and carefully. I fully agree with the question and the comment that MRAs have got comparatively lesser benefit in the short run. They prevent fibrosis and remodeling in the long run. So even if you defer 2 weeks, okay, that's fine. But we have generally seen that starting a very small dose of eplerenone early in day 2 or day 3 really doesn't create much of hyperkalemia, and they tolerate it very well. In fact, the hypotension is much less with ARNI, with MRA. Eplerenone you can easily start, and they tend to benefit very, very well. The others, you need to start on small dosage and see that they are not getting electrolyte disturbance, not getting hypotension, not worsening their GFR. These are the main 3 challenges. As long as you can do that, and we always say, Professor Wander said it many times, simply because your creatinine has slightly jumped up, don't back out. 20% creatinine rise is normal after starting an ARNI. Keep going and watch how the gradient is, how your creatinine is moving up. If it's not hypotensive, if it's tolerating well, probably it is just a short-run thing where we know that the long-term benefit would be there and his creatinine would settle down. Professor Wander, your comments, sir?
I agree with you, Dr. Tiny. Actually, it's a beautiful question, and you dealt with it very well. As physicians across the country and the world realize that these 4 pillars have to be started on all patients, the obvious question is, and you showed so beautifully that the benefits come up within a couple of weeks. So the obvious question in the mind of a astute physician would be how sequentially I can start. Well, most of these patients actually pre-discharge, you would like them to be on as many pillars as possible. The first drugs that you will start in your patient is a RAS blocker, because when patients are acutely sick, you will put them on a diuretic and a RAS blocker. But by the time your patients are acutely treated, actually, you will quickly add on beta blocker to the patients, because you will maintain their heart rates in a better way. The advantage of SGLT2 inhibitors is that they do not affect hemodynamics to a very large extent, although they do cause some blood pressure lowering and diuretic effect. As far as MRAs is concerned, I fully agree with Dr. Anand and Dr. Tiny Nair that if you look at the previous guidelines on heart failure, the MRAs are an add-on agent after you have put your patients on these agents. One has to keep in mind because potassium very often goes up. So once you have a RAS blocker with a MRA, potassium monitoring needs to be done more frequently. But as the question implies, and as your beautiful slide showed, that just as we realized actually with statins, we started using statins in patients of coronary artery disease, and then we had data to our surprise that statins should be used in patients with acute coronary syndrome in a high dose because it gives early benefit. So same is actually the four parts of the slide that you showed, that all these drugs are effective early, and our endeavor should be to, I can recollect one study which looked at beta blockers and RAS blockers. It showed that beta blockers even impart earlier benefits than RAS blockers, but we do know patients' heart failure should be somewhat controlled. So yes, it is a debate and it is an endeavor on the part of all of us to give all these four agents as early as possible.
Thank you, sir. So the next question is from Dr. Shailesh, who asks, do you have a differential placement in clinical practice for carvedilol versus bisoprolol, considering one is an alpha-1 beta-1 beta-2 and the other is a purely B1 blocker? So from a clinical profile perspective, are there two different types of patients you would give a carvedilol versus a bisoprolol?
Yeah, I think first of all, we should realize that there's no head-to-head data apart from that small COMET trial between carvedilol and bisoprolol and metoprolol sustained release, the three beta blockers that we use commonly, which are evidence-based medicine for treatment of heart failure. But there are tips and tricks from us. These are not supported by data, but over the years we have learned. See, the benefit of bisoprolol is it's highly beta-1 selective, right? So if I have an asthmatic patient, a patient with a bronchospasm, okay, he is very likely to tolerate bisoprolol very well without producing bronchospasm, right? On the other hand, if you have, that carvedilol has got an alpha effect also, number one. And second thing is carvedilol's advantage is it is available at 3.125 milligrams. Now, for a practical purpose, suppose you had a very bad cardiac patient who had just come out of a ventilator and, he's on a borderline hemodynamics. You say that, can we start beta blocker? At the bedside, two of your colleagues say, no, we should not touch him with beta blocker. The third person says, maybe we should, he would benefit and all that. That patient, it is easy. I won't say that there's any data to the contrary, but it's very more comfortable to start a carvedilol, 3.125. You can go home and sleep because nothing much is going to happen, right? So when you are looking at a beta selectivity, whether it is erectile dysfunctioning hypertension or whether you are talking about peripheral vascular disease, bronchospasm, tend to choose something that is highly beta selective. When you are talking about a very unstable patient, you tend to choose carvedilol. Also understand that carvedilol today is the kind of drug of choice for the hepatologists for liver portal hypertension. They have thrown away all the propranolol and they're going for carvedilol. So if you have somebody with an additional probably portal hypertension who has been drinking alcohol and has got a liver disease, another indication for going in for carvedilol. But very sick patients, we tend to give carvedilol. Highly prone for beta-2, beta selectivity is needed because they're likely to develop beta blocker-induced side effects. We tend to go for bisoprolol.
So the next question, we have two more questions in the interest of time, which we'll take, sir. So the next question is first to Professor Wanda, and we'll also have Professor Tiny Nair, sir, give his expertise to it. Device therapy, what, when, where, how? So if you can briefly just touch upon this, I know it's out of the scope of the current presentation. Professor Wanda, over to you, sir. Device therapy, what, when, where, how?
So that's a good question, actually, for the sake of completion of the whole discussion. Devices are very important, actually, in patients of heart failure. Devices, if we essentially look at, is cardiac resynchronization therapy. And now, of course, we have the bundle pacing also, which comes in the ambit of cardiac resynchronization therapy, what we call as a biventricular pacemaker. And you can have an ICD combined, what we call as a combo device, when we have an ICD with a biventricular pacemaker. Any patient who has actually a left bundle branch block and has a QRS more than 0.15, and in addition, if the PR is prolonged, there is some mitral regurgitation, they are the ones who are going to respond better actually to the cardiac resynchronization therapy. So all patients who have actually a QRS prolonged beyond 0.15 with left bundle branch configuration and some MR, some PR prolongation, they should be offered. And we know almost 2/3 of them respond beautifully. Patients' ejection fractions improve. One has seen ejection fractions improve remarkably with beta blockers, and similarly, the ejection fractions at times come back to normal with the CRT. The second, of course, is the automatic implantable cardioverter defibrillator, the ICD. Now, any person beyond 6 weeks after MI, we have data as for primary prevention as well as for secondary prevention. Primary prevention is when someone has just a low ejection fraction. Now, keep in mind that coronary artery disease related, ischemic cardiomyopathy related heart failure responds better, have greater benefits in terms of mortality reduction with ICD as compared to patients of dilated cardiomyopathy. But there is data that even in that subset it is beneficial. But certainly patients of ischemic cardiomyopathy 6 to 8 weeks beyond MI who have ejection fractions of less than 30%, it's a class 1 indication to give them. I know world over it's not possible. People don't give it, but there is a benefit. Certainly patients with secondary prevention, or those who've had episodes of VT documented and who have had cardiac arrest and revived, there is no two opinion. So for primary as well as for secondary prevention, these people with low ejection fractions, they benefit from ICD, those who have LBVPs, and they benefit from. As far as mechanical assist devices are concerned, I think that's for another day, because patients now we have data that mechanical assist devices can be used as the end-on treatment only, rather than as a bridge to the heart transplantation. So those are patients who are very low ejection fraction, very sick patients. They would be candidates for mechanical assist devices for these people.
Thank you, sir.
Nothing to add. Perfect answer.
Thank you, sir.
Only
So we
only
go to the
understand that today, even device therapy, even our data, if you see, device therapy implantations have significantly come down compared to the last decade because the drugs are so powerful. So as we use the GDMTs in a good manner, even the incidence of our need for device therapy has significantly come down. That is for sure. But there's nothing to add. Nobody can summarize device therapy in 2.5 minutes as good as Professor Wanda. Perfect.
Thank you.
So we come to the last question of the day. So this is from Dr. Divya, who asks, the placement of Versigouet in clinical practice in Indian settings, is it truly the touted fifth pillar, as some say? So we would like to hear both of you.
See, this is something that has been debated often. Yes, Versigouet is good. There's one major trial with Versigouet. We are awaiting the rest of it beyond Victoria. And in Victoria, we saw that there has been benefits, not in terms of survival, but combined endpoints have been benefited now. So the data is not as strong enough as the other four, number one. Second thing, the cost is still high. But one good thing is, since we have used now quite a lot of Versigouet, it is it's tolerated very well. Hardly any patient will come and tell you that I had a side effect with Vericiguat. People will tolerate it very well. Hardly anybody drops out. But the benefit, even if you look at the data, is reduction of heart failure hospitalization. So I would say today in India, whom should you give Vericiguat? I will prescribe it for a patient who, on all 4 guideline-directed medical therapy, continues to come to my hospital and get admitted 1, 2, 3 times. And these are the patients who we have actually given Vericiguat. And did it help? We don't know. We have a feeling that yes, it is tolerated. It probably helps in reducing hospitalization. Other data, we have to go by the published data because, by giving 10, 15 patients, we can't really. I can vouch that it is very well tolerated. Patients whom we have given have not said that there is a side effect with it. But the benefit, we don't know. We are giving it probably far late in the should we give it earlier? Maybe, but the cost today prevents us from giving it to patients who are already doing that. So right now, somebody asked that question like Dr. Divya asked, prescribe it for your patient who is coming for recurrent hospital admission despite being on standard 4 drug therapy of heart failure.
Thank you, sir. Wanda, sir, any?
I fully agree with what Dr. Tiny Nair said actually about this add-on drug only in resistant patients who have been hospitalized. I would say as a clinician, actually, advise Dr. Divya and others, spend a lot of time with your patients of heart failure. And there are other 3 things in our country which are more applicable, giving them treatment for anemia at times, iron deficiency, looking at their vaccination status. As Dr. Tiny beautifully said, actually, I do very often tell them to have a weighing machine out of all these things, the most important thing, weigh there, and then they can predict virtually that they are accumulating drugs that they should avoid, drugs that can precipitate heart failure, infections when they need to report early to the. So it's a whole lot of concept. Actually, heart failure patients should not be treated the same way as we treat other less dangerous diseases. And very important, once the ejection fractions improve, do not stop treatment, then continue with these drugs, which are actually affecting the neurohormonal systems.
Thank you, sir. So with the same, we reach the end of the audience Q&A. We have the actual numbers of doctors who have joined us. We have had 3,500 plus logins as of now. And the beauty is the logins have been constant. It's not that people have logged off or relogged back in. So the interest level has been continuous. We are very sure that the audience who is... नहीं sir, जरूर नहीं किया. But and the response is evidence of the same.
No, sir. Even I got the message from the technical team. Like first time we have got so many people on live. They are watching it, sir. Like 3,000 current update is 3,035 number. 3,535, sir. And maximum number of people are live. Thank you so much, sir.
With that, we come to the end of this wonderful academic feast. Professor Gurpreet Wanda sir and Professor Tiny Nair sir, it was a feast to hear both of you, and we are very sure the audience too has reciprocated in exactly the same way. Just to say, in Mumbai we are actually fighting rains right now, and we are very sure a good amount of audience which has attended here in Mumbai also has logged in despite all the challenges here in Mumbai right on time, and it. Based on whatever geographical data we are getting, I believe it is something across the country. The interest is right from north, south, east, west. We've got logins from all parts. We are hugely thankful to both of you for the wonderful talks that were delivered, Professor Wanda and Professor Nair. Always a pleasure and an honor to host both of you. Dear audience, we are also thankful to each and every one of you for actually taking your valuable time to come here, take in your messages, and we are very sure that the learnings from this webinar would ultimately empower you in your clinical practice to ultimately improve patient care outcomes. Last but not the least, we are also thankful to our technology partners, DocMode, for aiding in the very smooth streaming of this webinar. Thank you, one and all.
You should also tell Dr. Charmi that she had been fantastic. Never looked at you
Thank you.
for the first time. You did a professional job.
Without doubt, sir. Without doubt, sir.
Thank you so much, sir.
Thank you, sir.
Thank you. Wonderful.
Thank you so much, sir. Thank you, sir.
Thank you, sir. So congratulations, Mr. Akhil. Congratulations, Dr. Charvik.
Well,
We'll have to log
finally-
out. We'll have to log